Welcome to the Deep Dive. Today, we're jumping into a topic that's, well, absolutely critical if you're an orthopedic resident, gearing up for those postgraduate exit exams. We're talking patella fractures.
Hmm.
And this isn't just skimming the surface. We're aiming to really pull out those crucial insights, maybe some unexpected bits, and the practical stuff that gives you an edge, for the exams in the OR.
Absolutely. It's core knowledge.
So our whole chat today is grounded in the Ortho Made Simple notes you can find over on mokyingren.sg. They were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore. Finished his FRCS back in 2022. Really great resource.
Very solid notes.
Think of this as your shortcut to grasping the key ideas and the clinical thinking you really need. Okay, let's unpack this, starting with the diagnostic side of things.
Right. Because, distinguishing a true fracture from, well, something else entirely is step one. It's foundational. Getting this right isn't just academic theory. It's vital for managing patients correctly. And, yeah, for those exams where they love to test the nuances.
That takes us straight to a really interesting point from the notes about that initial look, the evaluation.
Yeah.
It's about the contralateral x-ray. Taking a picture of the other knee when you suspect a patella fracture. Why bother?
Yeah. Seems basic, but...
Well, the main reason highlighted is to spot a bipartite patella, which is basically a patella in two pieces because it never fully fused.
a congenital thing.
Exactly. And what jumped out at me from these notes, the bipartite patella, is actually bilateral, meaning in both knees, in 50% of cases, and usually found up in the superlateral corner. That 50% figure, that's pretty striking, isn't it?
It is surprisingly common, yes.
So what's the absolute key thing for a resident to remember here to make sure they don't mismanage things because of this? What's the trap?
What's fascinating here is how that simple step, just getting an x-ray of the other side, can be the deciding factor. Is it something they were born with, or is it a fresh injury? For you as residents, recognizing bipartite patella is crucial. Why? Because if you mistake it for a fracture, you could end up doing unnecessary investigations, maybe even surgery, for something that's perfectly normal for that patient, just, their anatomy.
So the pitfall is jumping to conclusions.
Exactly. Don't just assume fracture without considering these variations, especially if the story, the mechanism of injury, doesn't quite add up. Remember, a fracture usually has sharp, jagged edges. A bipartite patella, smooth, well-defined, corticated edges. Big difference on the x-ray.
Okay, good. So once we're confident it is a fracture, say a simple transverse one, how do we fix it? The Ortho Made Simple notes really hammer home the tension band wire technique. That's the main player here.
The workhorse.
The notes go through it step by step. Patient supine, tourniquet, side support, midline incision, expose it, reduce it with temporary K-wire.
Crucial step, that reduction.
Then the figure of 8 tension band wire itself. And checking the reduction with a little peek inside, a mini arthrotomy on the medial side.
Verifying the joint surface.
And then post-op, knee brace, gentle passive motion, 0 to 30 degrees. Keep it locked straight when walking and schedule follow-up x-rays. Seems straightforward enough on paper.
It does, but the devil's in the detail.
Right. And the notes also bring up a really important question about the principle behind tension band wiring. Why does it actually work? They flag that as fundamental.
If we connect this to the bigger picture, mastering the technique is one thing, knowing the steps. But understanding the why, the biomechanical principle, which those notes rightly emphasize, that's key. From all those steps you listed, I'd maybe highlight two things. First, getting that perfect anatomical reduction. If those fragments aren't lined up just right,
the whole thing fails.
Well, the tension band won't work as intended. You'll likely get a step in the joint surface, which leads to arthritis down the line. Second, applying that figure of 8 wire correctly. It has to actually convert the pulling forces, the distraction forces from the quad muscle into compression right at the fracture site. Understanding that principle, how it generates compression, is what makes it such a stable fix. It's not just wrapping a wire around it.
That makes sense.
Yeah.
Reduction first, then applying the force correctly based on the principle. So what about when it's, messier? Not just a nice, clean transverse break.
Good question, because you see plenty of those too.
What do we do then?
This raises an important question for residents, right? When do you pick one technique over another? What are the trade-offs for the patient's function later on? Because the fracture pattern really dictates what you can and should do surgically.
Exactly. And the Ortho Made Simple notes give us some pathways here. If it's comminuted, shattered into multiple bits,
Smashed up.
then Circlage wiring is suggested, basically wiring the pieces together.
Like putting a hoop around them.
Then for those really tricky fractures way down to the bottom tip, the distal pole, especially if the fragments are tiny.
Not much bone to grab onto there.
The notes suggest using an intraosseous suture, stitching through the bone itself.
A good option sometimes.
But then there's the worst case scenario. The patella is just so badly damaged, it can't be put back together.
Irreconstructible.
In those situations, the notes say, a patelectomy, taking the patella out completely, is the only option left.
Yeah, and that's a big decision. A comminuted fracture needs that circlage to gather everything up. A distal pole fracture with tiny bits, you often just don't have enough solid bone for screws or wires, so sutures through bone make sense. But patelectomy, that's salvage, really. You only go there when you absolutely cannot reconstruct the native patella because it's too shattered or the pieces aren't viable. Understanding why you choose each one, the decision-making, that's crucial for you as residents. Each choice has different implications for the patient down the road.
So let's talk about those implications.
Yeah.
If a patelectomy is necessary, what does that actually mean for how the knee works long term? The OrthoMade Simple notes are pretty clear on two major effects. One, left quadriceps strength, and two, more instability.
Significant consequences, both of them.
Let's dig into that strength loss first. The notes say taking out the patella cuts quad strength by about 20%. That's quite a chunk.
It is. 20% is noticeable.
And the reason is fascinating. Biomechanically, it's about the moment arm.
The leverage.
The patella acts like a spacer, pushing the patellar tendon forward, away from the center of the knee joint. This increases the leverage the quad muscle has to straighten the knee.
Yeah.
Especially when the knee is bent, and the tendon would normally sit in the trochlear groove on the femur. Take the patella away.
You lose that mechanical advantage. The quad has to work much harder to produce the same extension force.
Understanding these specific functional deficits is really crucial, isn't it? For managing expectations, planning the rehab.
Absolutely. That loss of leverage is a direct hit to the muscle's power. It's a permanent biomechanical change. It just shows how important that little sesamoid bone is for the whole extensor mechanism, not just a floating bone cap.
And then there's the instability issue. How does removing the patella make the knee less stable? The notes explain that the patella normally helps guide the patellar tendon, keeping it sort of parallel to the PCL, the posterior cruciate ligament.
An underappreciated role.
And this alignment actually reinforces the PCL's job in preventing the shin bone from sliding backward. But after a patelectomy, that guidance is gone. The tendon isn't parallel anymore.
Right, the line of pull changes.
Which over time puts extra stress on the PCL and also the posterior capsule of the knee. They get stretched, become less reliable, boom, instability.
That's exactly it. The patella isn't just part of the engine, the extensor mechanism, it's part of the steering too, guiding that tendon. Lose it, and the knee's kinematics change. That extra load on the posterior structures can definitely lead to a feeling of giving away or just, chronic instability.
Especially going down stairs or hills, I imagine.
Precisely. Activities with eccentric quad control under load. It's a powerful reminder of how interconnected everything is in the knee. And it highlights why preserving the patella reconstruction is always, always the goal, if remotely possible. Patelectomy has real functional costs.
Okay, so let's wrap this up. What does this all mean for you, the resident listening, as you study for exams or head into the clinic? We've unpacked some key things today, all drawn from those OrthoMade Simple notes on mokyingren.sg. First, the diagnostic trap of the bipartite patella and how a simple contralateral X-ray is your safety net. Don't forget that 50% bilateral rate.
Crucial point.
Second, for simple transverse fractures, we looked at the tension band wire technique, not just the steps, but stressing the importance of reduction and understanding the principle behind it.
Get the why, not just the how.
Third, we touched on the different approaches for more complex fractures, circlage sheavers for comminuted, intraosseous sutures for those tricky distal pole ones, knowing when to use what.
Matching technique to pattern.
And finally, the significant functional hit from a patelectomy, that 20% quad strength loss due to the lost moment arm, and the increased instability from altered mechanics.
Real consequences.
This knowledge is gold dust as you prepare. Really internalize these points.
And maybe here's a final thought to chew on as you consider all this. As you look at the whole spectrum, from simple breaks to unreconstructible disasters, think about where innovation might take us. How can new approaches, maybe new materials or techniques, help us minimize those long-term functional problems we talked about? How can we push the boundaries of what's actually reconstructible? And what impact does that ultimately have on getting patients back to the lives they want to live? Something to ponder.
Great point. Always more to learn, always room to improve. Keep applying these insights, keep questioning. Thanks for tuning into the deep dive. And remember, this deep dive was based on the Ortho Made Simple notes from mokyingren.sg. We'll catch you next time.